Hi. Today, I'm going to be joined by my colleague, and we're going to present models of care at home, hospital, and palliative care at home. I'm Linda DeSherry. I'm the Vice President of Clinical Strategy and Implementation at Medically Home, and I'm also a clinical professor at the Brookdale Department of Geriatrics and Palliative Medicine. I'm joined by my colleague, Dr. Meng Zhang, who's the Medical Director of Palliative Care at Home program in the Department of Geriatrics and Palliative Medicine at Mount Sinai. I have one disclosure to report is that I'm the full-time employee of Medically Home, which partners with health systems to operate hospital at home programs. Dr. Zhang has no disclosures. In our lecture today, we're going to talk about the home care continuum, but really spend most of the time focusing in on hospital at home and palliative care at home. I want to acknowledge three sources of funding for our work. Hospital at Home was funded both by CMS for a Center for Medicare and Medicaid Innovation Award to Mount Sinai from 2014 to 17. And then a lot of the research on hospital at home and the hospital at home users groups have been funded by the John A. Hartford Foundation. Then the West Health Foundation has supported the palliative care at home program over many years. So I'm first going to start with care at home in general. And I love this schematic that the California Healthcare Foundation created, which shows on the x-axis a continuum of like chronic longitudinal care all the way over to acute episodic care. And on the y-axis, really no medical, no physician or nurse involvement up to high really physician and provider level support at the top of the y-axis. And you can see on here a variety of home care models, programs that are out there, with hospital at home really showing kind of the high acuity and high physician involvement. And you can see that home-based palliative care is less acute, more chronic longitudinal care, but kind of in the middle of physician involvement. And Meng's going to really talk about a lot of the variety of models of that, while hospital home kind of more often sits squarely in that top right corner. And why do we even talk about care in the home? Why is this important? You know, hospitals were created, everyone went to the hospitals or everyone went to physician offices. Why are we talking about this change to care in the home? And really, this is a lot been driven by patients themselves. They have increased satisfaction and family engagement by having care at home. We believe that we can provide equitable access despite health or social needs for patients at homes. There's a potential for lower cost, improvement in workforce. You've seen so many providers in the workforce kind of stressed and burnt out, especially during the pandemic. And high quality care with lower readmission rates, reduced hospitalizations, a lot of very positive healthcare outcomes, all by keeping patients in the center and providing care in the home. And so these are some example pictures here, just showing what is possible in the home. You know, from the hospital at home on the top left, and you can see even chronic care at home with lots of technology and how we actually provide this care for patients. And this is why I love providing care in the patient's home, in their center of care. So I'm going to spend now some time talking about hospital at home. We're going to talk about the origins of hospital at home, the definitions and some models, outcomes, payment and advocacy of hospital at home, and some resources for anyone wanting to learn more about hospital at home. So let's talk about the origin of hospital at home. And I'm going to start this with a case. So Felicita is an 82-year-old woman, and she lives in the same building as her daughter, but she's alone at night. She has an aide with her during the day. She has multiple chronic conditions. She takes a number of medications, and she's been admitted a number of times. But significant conditions include dementia, CHF, and she's now presenting now with pneumonia to the emergency room. The emergency department team evaluated her and started antibiotics. And she meets inpatient level of care, and she's expressed a desire to not be admitted and wants to go home. We're fortunate enough that in this case, there is a hospital at home program associated with this hospital. And she had an H&P conducted by the hospitalist service, and she was transferred home by BLS ambulance with her daughter. She was met at home by a nurse. The tech was set up in her home. Oxygen was set up. Meals were delivered. She got a new walker and bedside commode. And she continued to receive antibiotics and improved. Her oxygen was weaned down, and she was discharged after 3 days to home health. And this is just a wonderful story to show what hospital at home is possible. But what is a typical brick and mortar experience for a geriatric patient? And so this is really where the origins of hospital at home came from. Geriatricians were frustrated with some of the continuum that happened, the norm that happened. There's crowded, long wait times in emergency rooms with risk of hospital-acquired conditions already. Then you are in the brick and mortar, away from loved ones and familiar environment, especially challenging for someone with dementia. And then hospital-acquired conditions such as delirium, falls, ulcers, infections can happen. And then because someone becomes debilitated, they end up going to post-acute care, which has its own risks of institutionalization and other acquired conditions. And I'm not advocating that we should never have hospitals again. We will always have hospitals. We need hospitals. We need them for ICUs. We need them for emergency rooms. We need them for surgery and some of the medical conditions. But for the conditions that we can now take care of hospital at home, you can see what a wonderful outcome Felicita had versus what might have been her usual trajectory in brick and mortar care. And so what's the history of hospital at home? Some people are like, I've just heard of this very recently, but it's actually been around since the 1960s in France. And then in the 1970s to 90s, there were so many programs that started internationally. Canada, Australia, New Zealand, Israel, United Kingdom, and Spain are some of the larger countries that have robust hospital at home programs. In the mid-90s is really when it started in the United States. Some researchers, including Bruce Leff at Johns Hopkins, began the first programs at that time. And then there were a number of publications that came about a decade later, including the VAs. Not a lot happened between 2005 and 2014, and a lot of it got stalled because of no payment for it. The outcomes were established. It was a better outcome for patients, less readmissions, some of the data that I'll present in the future slides. So in 2014 at Mount Sinai, we were fortunate enough to receive this large CMMI award to look at patients both for their acute episode at home and to take care of them for a 30-day episode to try to look at the whole picture. Could we prevent those readmissions at the same time, as well as reduce the complications that could have happened in their hospitalization? In 2018, at Brigham and Women's, they published the first RCT of home-based, of home hospital, which showed the very similar robust outcomes, but nice to see it now in an RCT. In 2019, we founded the Hospital at Home Users Group, which is open source material for everyone to learn about hospital at home. And it also is providing some standards and work groups to advance the model. Then the pandemic happened. And in November 2020, CMS agreed to cover hospital at home at the same DRG rate for a hospital that has been approved to do so. And we call that the waiver. The waiver waives the 24/7 on-site nursing requirement that a hospital has, and some of the life safety codes of smoke detectors and fire alarms, et cetera. So that really was, a wonderful thing that happened in the pandemic, where there was this bed crunch to allow for the advancement of hospital at home. And now in August of 2024, there's 338 hospitals in 38 states that have been approved for the waiver. There are still programs that exist that don't use the waiver if it's run, has a different source of payment. So it could be a hospital that uses a lot of value-based contracts in all their MA and commercial plans, or it could be a payvider that helps support a program like this. So I'd like to talk a little bit about the definition of hospital at home, because I think a lot of people, when they start thinking about it, they're like, oh, that makes sense. But then when you get to the technicalities of it, they waffle between inpatient and outpatient and home health. So the World Hospital at Home Congress in 2013 helped define what hospital at home is. And I'd like to read this. This is: a hospital at home is an acute clinical service that takes staff, equipment, technologies, medication, and skills usually provided in hospitals, and delivers that hospital care to selected patients, people in their homes. In nursing homes is in parentheses because internationally that's a different regulation than in the US, where it's not possible currently. And it substitutes for acute inpatient hospital care. It's not OPAT. It's not a transitional care program. It's not home-based primary care, and it is not skilled home health. So I think those are important differences for what hospital at home is. So now we'll get a little more into the details. So most common kind of hospital at home use cases, the waiver requires that patients come from an inpatient source, so an emergency department, med surg, or PACU. If you don't operate on the waiver, you could also take from an outpatient clinic or find patients at home. But this slide is mostly covering the waiver, which is a majority of the programs out there today. So patients are either usually in categories of acute hospital sub, which means they're taking the entire hospital episode straight from ED to home, or they could have been on the inpatient unit or PACU and now coming home, which has a little bit of a misnomer of reduced length of stay, or otherwise known as completing hospital at home. And most programs run lists of patients so you can quickly identify that they have the right reimbursement source, right insurance covering this, that they live in the geography that the program has determined that they are providing care in, that they truly meet inpatient care. And then there's usually a clinical stability assessment done, a social assessment done. And both of those, I really want to emphasize, it's not to exclude patients, but it's to really make sure the patient has a home and the capabilities clinically that can be taken care of there. And then, of course, there's patient choice. Then they're transferred home, and programs are inpatient. So it's physician-led care with daily physician provider visits, nursing visits that are multiple times a day. 2 in-home clinical visits are required under the waiver, and then in-home diagnostics, so labs, all the other services that are needed. And some programs insource that. The hospital provides all that. The pharmacy internally gets all the meds couriered home and labs couriered back. And some are done by outside vendors that are contracted to operate under the hospital. So think of all the normal things on a gen med floor or a med surg floor that are taken care of in this program. And then they are discharged in the same way with a discharge summary and connection back to their primary care provider. And then what does that kind of look like on another level? So that's the timeline of patients, but who takes care of things? And so most programs have a command center that may be a physical or a non-physical place, where that means that they have a group of physicians who are going to do video visits with the patient in their home and sometimes go to the home as needed for those patients. There are nurses 24/7 available to those patients and to be able to urgently respond to things and do medication witnessing and all the requirements for this program. Most programs also have advanced practice providers. Maybe they're helping identify patients on the inpatient units or ED, and some of them are augmenting the physicians in the ongoing care of the patient. Most programs are using the EMR that is the EMR of the hospital. I mean, this is a virtual unit of the hospital. And then this middle category, this is what, at the company I work at we have a program called SAISHA, which helps the collaboration and the coordination of everything in the patient's home. There are other programs that are doing this with spreadsheets and other ways of coordinating everything in the home. And I would say most programs have technology in the home. They have some sort of tablet and peripherals to help the patient, which I'll show an example of in a minute. And then they have all those things I talked about. How are they going to get everything that needs to be in the patient's home and organized and rapidly sent out to patients based on their acuity? And here's an example of what a rendering of a command center could look like. And these are some examples of what a in-home provider might have available to them with point of care testing and ultrasound and even some medications urgently available, all connected back to the command center physician or APPs, nurses. And this is an example of the tech that might be in a patient's home. So peripherals like a blood pressure and a pulse ox, a scale, a tablet to help the patient have those video visits, a router to make sure you're not required to be on the patient's Wi-Fi, and other things. Some companies use a PERS device and a landline like looking phone to help supplement that in-home devices. So now let's get to outcomes of hospital at home. So as I mentioned at Mount Sinai, we had this large CMMI grant, and we studied patients over the 3-year period. And those patients all came from the emergency room. So little different than the waiver that allows both from the inpatient unit. But these all came from the emergency room, and they also had a 30-day transitional care episode. But you can see in that, with those background, they had a shorter length of stay than our control patients, with less readmissions, about half as many ED visits, with higher overall experience rating, and much less discharge to skilled nursing facilities. Another study, this is when Mount Sinai first launched patients being discharged from the inpatient units during the COVID crisis. And you can see within the first 30 days, there were already 75 hospital days averted with a new program in the acuteness of COVID. So you can see how hospital at home can help multiple outcomes, help the patients, as we've been saying a number of times, but also help with bed crunches, which many hospitals are facing, COVID and beyond. So now I would like to talk a little bit about, and those are just two examples, I should say, are two examples of studies that exist out there. There are many more internationally and nationally that have shown many of these very positive outcomes. So now I'd like to turn to payment and advocacy of hospital at home. So as I said, a majority of the care right now is being done under the waiver. There are 336 hospitals in 38 states that are being approved for that. Right now, the waiver will expire at the end of this calendar year, 2024. There is a great push for another extension, and hopefully it'll be a 5-year extension for continuing this waiver. As I said, there's a lot of advocacy happening right now on that. There is a lot of a positive movement in that. And CMS will issue their first report of the second 2-year waiver extension at the end of September. So soon after the CME course is over. But as I said, it's not the only way this is paid for. There are lots of programs out there that are negotiating with Medicare Advantage and commercial. It could be an episode rate like a DRG. or a bundled rate for 30 to 60 days with quality outcomes. We also have about 10 to 11 states where Medicaid is paying for this, and we really believe that that needs to be a much more significant push. There's great willingness, but many of the Medicaid offices are struggling with workload to get this pushed through. But we are still thinking positively about this happening in the future to allow equal access to programs where they exist. So if you are interested in thinking about hospital at home where you're working, or just want to learn more about this, I put two resources on here. The Hospital at Home Users Group, I am one of the founders of it, but it's an open source group for anybody interested. There's a technical assistance center, there's webinars, there's an annual meeting, and lots of great things to check out on that website. And the other big organization is the World Hospital at Home Congress. They meet every 2 years, but it has also a lot of great information on their website if you are interested in the model internationally. And with that, I'm going to turn this over to my colleague, Dr. Zhang, who is going to speak about palliative care at home.
Thank you, Linda. Hi, everyone. In the next 20 minutes or so, I'm hoping to present the case for home-based palliative care, provide some evidence for its benefit, discuss different models, revenue streams, and staffing mix for existing programs, and introduce you to the Mount Sinai Palliative Care Home Program, as well as some lesson learned. Next, yeah. By 2030, an estimated 73 million people in the US, which is 21% of population, will be over age of 65. And by 2034, older adults will outnumber children for the first time in US history. As population ages, the number of people living with multiple chronic conditions and serious illnesses continue to rise and place a growing burden on the health system. Many of these individuals suffer from cognitive and functional impairment and have difficulty or needing assistance leaving the home. In 2011, an estimated 2 million individuals were homebound, and this figure is expected to grow substantially as the baby boomer generation ages. These individuals often have very complex medical needs with high symptom burden, compounded by poverty, isolation, and often limited health literacy. In addition, while short-term mortality rates in this population are high, about 20%, many have unpredictable prognosis or may not wish to forego curative treatment, rendering them ineligible for hospice care. For this population, home-based palliative care offers great benefit. While both hospital and the clinic-based palliative care services have grown substantially in the past decade, the growth in home-based services have lagged behind. This gap represents opportunity to enhance the quality of care for community-dwelling adults with serious illness, improve care transition, and avoid hospitalizations while these are unwarranted or unnecessary. Next slide, please. Now, it sounds nice to have more access to palliative care in theory, but is there any evidence that home-based palliative care actually improves quality of care? Research is lacking in this area as for palliative care as a field in general. But there are some existing literatures and studies looking at symptom improved management, satisfaction with care, place of death, hospice enrollment, acute care utilization, as well as cost of care. Home-based palliative care is shown to improve patient symptoms, resulting in higher patient and caregiver satisfaction. While not everyone's preferences, the majority of people, including those with advanced illness, would prefer to die at home. Home-based palliative care, often in conjunction with hospice, later in their disease progression, is associated with a reduction in hospital death. While we know enrollment in hospice at the end of life is associated with improved outcome for patients and caregivers and the reduced cost of care, we also know very well large proportion of decedents never access hospice, and among those who do enroll is often close to death. Because home-based palliative care encourages proactive discussion around disease understanding and preferences for care to ensure a coordinated transition to hospice care, if that's aligned with patients' preference and values, it has been shown patients who are enrolled in home-based palliative care were significantly more likely to have received hospice. Studies have also showed a reduction in inpatient hospitalization and emergency room visits with patients enrolled in home-based palliative care programs. This likely reflects the consequence of a well-coordinated proactive care as well as early goals of care discussion. The impact of home-based palliative care on total cost of care has been examined in a number of studies, mostly looking at Medicare claims data. As one would expect, there's more evidence for cost saving in the last year of patient's life for patients enrolled in home-based palliative care program. Next slide. Until recently, home-based palliative care programs were operated by a small group of progressive health systems and community agencies. There has been a rapid expansion in the number of these programs in the US in recent years, fueled by evidence from studies demonstrating the beneficial impact on outcomes for patients and the potential to generate savings within value-based care arrangement. In common, all models center on an interdisciplinary team trained in the principle and practice of palliative care. For the interdisciplinary team, seeing patients in their own home affords a unique perspective on the patient's life and the fuller picture of the patient as a whole person, a principle that is essential to palliative care. It allows the clinical team to assess patient symptom burden and functional status in the context of their own environment, to meet separately with family members and caregivers to assess caregiver burden and provide support, and to rapidly assess the social determinants of health. Finally, the home can provide a familiar and comfortable environment within which to engage in challenging conversations. While the interdisciplinary team is a constant in models of home-based palliative care, there are many differences between programs which influence the delivery of care. Home-based palliative care programs in the US have emerged in general from 5 organizational homes: home health agencies, hospice agencies, hospital or health system-based programs that have expanded into the community, clinician groups, and finally, multi-state providers such as Aspire Health. Additionally, while home-based palliative care can be provided within a home-based primary care program through a team-based practice model, not all home-based primary care program will have this focus or the required training. The Mount Sinai Visiting Doctors Program is probably one of the best known examples of this model. Programs run at a home health agency are more likely funded through a regular home health benefit and thus required to follow the associated rules and regulations. These programs identify eligible patients on enrollment to ensure patients can be managed by the specific home health team that has training in palliative care. Within these programs, it is important to have providers with the capacity to go to the home to assess and provide care and suggest care plans to the primary care physician overseeing the episodes of care. Programs that are part of a hospice agency can act effectively to support patients' transition from home-based palliative care to hospice and may be sustained in part through revenue generated from the increased enrollment in hospice. Programs established by hospitals or the health system target patients with high needs and acute care utilization. These programs can bill for the professional services. Additional costs are often funded by the health system as part of a broader strategy to improve quality of care and generate savings supported by the value-based arrangement. Finally, programs that deliver home-based primary and palliative care bill for professional fees, but need additional revenue to sustain their program. This can be achieved through shared saving risk arrangement, such as accountable care organization, direct contracting, and the independence at home demonstration. And oftentimes grants and philanthropy are also part of the source of funding. Next. Now let's take a look at the staffing mix. While all home-based palliative care are interdisciplinary, the precise staff mixing and ratios can vary according to the population served and the financial sustainability of a model in any one market. Many programs are billing provider-led with additional interdisciplinary team members such as RN social work supporting delivery of a comprehensive care plan. The advantage of this model is the capacity to generate revenue through provider billing for visits. Rarely does this fee-for-service payment cover the cost of the entire team. Therefore, either a health plan or health system must cover the rest of the team cost. Other programs comprise almost entirely of non-billing staff, such as nurses, social workers, community health workers, with physician, nurse practitioners supporting being office-based triaging and care plan development. While these programs may not be feasible in a fee-for-service market, they do offer the advantage of being deliverable within the context of a shortage of palliative care providers and thus readily scalable. Another distinction between programs is how they work with the primary care providers. Possible models include consultative, co-management, or primary management. In the consultative model, the team focuses on specific needs, such as symptom management or advanced care planning, and provides recommendations, and the responsibility for implementing these recommendations resides with the primary team. In the co-management model, the palliative care at home team may also focus on specific needs, as in the consultative model, with the difference being that they will manage these needs. In this model, significant collaboration must occur to ensure everyone understands their responsibility as treating physician. Finally, in the primary management model, the team may assume all responsibility for the patient's care for a specified period of time, such as following a hospitalization. In the case of palliative care provided within a home-based primary program, the team assumes primary responsibility for all the patient's care until they transition out of the program. As in the case with the Mount Sinai Visiting Doctors Program, even when the patients transition to hospice, the home-based primary care provider will often remain as attending on record, working with the hospice team. This enables continuity of care while delivering the additional benefit of hospice enrollment. In practice, any one program may adopt different models with different primary providers and patients, depending on the preferences and competency of the primary provider, the patient's preference, and the competency of the home-based palliative care program. For patients lacking access to home-based primary care services, the home-based palliative care team can often end up taking on the role of primary care provider, simply by the virtue of their availability. While this is the case, it will be important to ensure that home-based palliative care team include providers with training in internal medicine or family medicine. Next slide. Now, let me introduce you to the Mount Sinai Palliative Care Home Program that I oversee. The evolution of this program very much reflects the healthcare climate and revenue stream for the given time. The program was first started in September 2017, about 7 years ago, as a pilot study. The think tank behind this study included Sean Morrison, Nathan Goldstein, as well as my co-presenter, Linda DiCherri. It's the first time a home-based palliative care program utilized community health workers as the foundation for the program. After receiving a grant from NIH, the program was part of a randomized control trial for palliative care at home for patients with dementia. Then came the COVID-19 pandemic. In response to the needs of the health system, the team quickly transitioned to a program that worked essentially as a hospice substitute, as most of the hospice at the time were not taking on new patients. After the randomized control and funding ended, the program fell under the joint venture Mount Sinai had formed with Contessa Health, now Amedisys, serving patients under a value-based contract. Next. The target population for the program are patients with a prognosis 6 months to 2 years with significant symptom burden or caregiver stress, or patients who are actually eligible for a hospice but are not ready based on their goals, or patients who have been declined by hospice because of their lack of involved caregivers. The program currently just serves one payer. It covers the entire island of Manhattan and parts of Queens. The model for this program is co-management, with the main workforce being the community health workers. The team is interdisciplinary with an MD, 3 NPs, 2 RNs, and the social work support. And typical length of care is about 12 months. Next slide. As I mentioned, this program really heavily rely on the community health workers, and they serve many roles, as you could see. They help monitor symptoms, serve as caregivers, provide caregiver support and education, serve as health coach. They help with medication reconciliation, communication facilitator, and often help with navigating community resources, as well as advocacy. Next. Some key attributes to any palliative care home team, one being the most important interdisciplinary team. The 24-hour, 7 days access to care is critical and paramount in ensuring avoidable ER visit and hospitalizations. We incorporate a comprehensive geriatric assessment and intake and try to involve behavioral health and provide social support. We provide early goals of care conversations as well as comprehensive caregiver support. Next. These are just another rendition of the team structure. Next. This is enrollment for the program criteria. Next. The findings of the randomized control trial were recently published in the journals of the American Geriatric Society. The study, like previous studies, demonstrated again improvement of symptom and quality of life compared to standard care. However, due to the COVID-19 pandemic and changes in grant funding, the study was not able to reach the intended sample size and sufficient statistical power to demonstrate significant difference in healthcare utilization and the costs associated with recipient of palliative care home. Next. Based on the experience for the last 7 years, there's some lesson learned and many questions that we are looking to answer, which include what is the optimal timing of enrollment in home-based palliative care, and to what extent is earlier enrollment in home-based palliative care program associated with improved outcome and cost saving. Which components of home-based palliative care are central to realizing quality? And how can telemedicine best augment existing models of home-based palliative care? Next. I won't read out these recommendations, but these are recommendations for people who are interested in starting a home-based palliative care program. Next. Again, why are we here? I'm going to take us back to the picture Linda has showed earlier with the crowded, chaotic emergency room, the 4th floor walk-up building where homebound patients are really essentially trapped. Next. We are shifting care outside physical facilities like a hospital and emergency room, as well as clinics, because home-based care can provide high quality and patient-centered care. It can also contribute to achieve health equity, provide an alternative care model for a burned out workforce, as well as serve as a relief mechanism for the health system. I'm going to end this talk with one of my favorite pictures. In many ways, I firmly believe home-based care is patient-centered care. And quite literally, the patient in this picture is the center of the focus. You have Dr. Felix Brickner, the founding chair of the community medicine department at St. Vincent Hospital in New York City, and one of the pioneers in home-based care, kneeling on the right, holding patient's hand, along with the social worker and the nurse, all as guests in patient's home. While time and technology may have changed, the human touch remains the foundation of home-based care. Next. This is a post-test question. The next slide has the answer. This slide has the keywords and take-home summary, which is hospital at home and palliative care at home are 2 models of care that have shown positive outcomes for patients. Thank you so much. These are Linda and my email in case anyone want to outreach. Thank you so much.